All right, everyone, we're here today with episode 3 of our Help Yourself Learning series. I am joined today by Amy McMillan. She is another physical therapist. I'm excited she's the first physical therapist I'm going to have on this. And I reached out to Amy. I discovered her company. And can you tell us the name of your company?
Custom Care Rehab, and it's a concierge or mobile physical therapy company.
About links to all that in the description. But I saw the work that Amy is doing and I was immediately jealous. I go, oh my gosh, she picked the perfect business model. I wish I would have done that. This is such a great idea. It's going to help so many people. So I wanted to bring her in, just share what she's doing, how she's helping people in the vestibular community, and how she's just doing great work as a physical therapist. So, Amy, I want to get into it. I just want to start. Tell me a little bit about yourself. What made you become a PT?
Um, what made me become a PT? I love serving others. I love basically helping. I was a cheerleader in high school, athletic trainer my last year. I knew that I loved kind of sports that got me into it. And then as I got into the PT program, just kept developing and finding these niches that I found interesting. And yeah, I love working with people and helping. So it's a good fit for me.
You have the one of the same origin, or you have the same general origin story as me. There's PTs. You meet enough PTs, you learn everybody has like one of 10 different like how I became a PT story.
Hmm.
Same thing for me. It was that was into sports. I got into athletic training, and then kind of got into it. I was like, I'm kind of over sports injuries. What else? What else can I do with this PT thing other than help somebody, throw a little better?
Yeah.
And me and you are both passionate about vestibular therapy. So many of the people listening may not really realize what vestibular therapy is. And even a lot of clinicians don't realize that this is something that we're trained in and that we can help in. So you want to just give us just, a 30, 60 seconds on what vestibular therapy is?
Yeah, I mean, I think most people think of therapists as somebody that can help with like a knee surgery or a shoulder surgery, but there's definitely so much more. So the vestibular therapist, if in a nutshell, any reason that you're dizzy, we can help identify the origin, help be the case manager with your doctor, and basically help you sometimes cure conservatively any reason that you're dizzy. So it's super effective. And, if you're with a trained therapist, they will figure out and devise why you're dizzy and come up with a plan to solve it.
So Amy, if I'm putting myself in the shoes of, the average person listening to this, I'm thinking physical therapy and dizzy. What's the connection? How is exercise going to make me feel less dizzy? That's not a concept that's very familiar to people. So if you were just given just a cursory overlook or overview of, how these interventions or how PT actually improves dizziness, where would be the first place that you would start?
A lot of our, you have to diagnose where dizziness comes from. A therapist can help with either central, peripheral, or non-inner ear related dizziness. So sometimes dizziness can come from the brain. Sometimes dizziness can come from the inner ear itself. And then there's other forms of dizziness that could come from non-vestibular conditions, like maybe it's orthostatic hypotension or a drop in blood pressure, or cervicogenic dizziness, which would be from the neck. Sometimes even anxiety related dizziness, which you wouldn't think a physical therapist could help with. But we're very well trained in how the body systems can overlap and cause symptoms. So, brain, ear, or non vestibular classification, and we can help identify where that's coming from.
And you're doing a lot of work, much like some of the work that we do. There's so many specific types of dizziness, and a lot of times that referral from the doctor, it doesn't say, left posterior canal BPPV with possible underlying 3PD. It just says, dizziness or
Yeah,
vertigo. So this is
yeah.
something even in the medical community that's not very well understood, and it is so comprehensive. The more I learn about vestibular, the more I understand what I don't know. And
Hmm.
each year, there's more and more diagnosis, more and more nuance to this. And they all require very, very specific management that not everyone is really equipped to have the time or the patience to really deal with. A lot of these, like a BPPV patient, you may be having better in one session.
Hmm.
Some of these other ones, I mean, you may be working with them for months on end to even start to see progress. And it's always nice to set those expectations with patients early on.
Hmm.
But just to kind of put a pin in this for people who aren't as familiar, um, there's a lot of different types of this dizziness that you talk about. Particularly the inner ear one is where we tend to get our most of our bread and butter.
Hmm.
Certainly the some of the other ones, but the inner ear definitely is kind of the one that we're gonna have the biggest impact, not the only
Hmm.
impact. Now, I'm like, as I'm saying that, I'm like, I do so much work with central stuff and the non ear ones. I'm like, I don't know, I'm pigeonholing myself, but I always think of like the BPPV
Hmm.
is such a big component, but it's not the only component. People that are that maybe do know about vestibular therapy, they just think, oh, they have these crystals in their ear and these PTs, they're kind of crazy and they tilt them back and they make these
Hmm.
crystals go the way they're supposed to. But it's so much more than that. It's eye exercises, it's
Yeah.
exercises, it's balance exercises. There's so much that goes into this. There's an anxiety
Yeah.
component. There's, let's learn some coping strategies. Let's learn some ways to modify your life. There's a lot of these different subtle things that go into it. And there's not a lot of clinicians out there that can put all those things together and maybe make it a little fun too, which is what something we try and do. And I'm sure you do as well.
Yeah, yeah, there's so many layers to that onion, and you're completely correct where, um, the diagnosis is dizziness. People come all the time. All you need to do is get your crystals reset. And you take the educational component and say, but you don't have any spinning when you lay down in bed or roll in bed. So that classification, that diagnosis doesn't fit. So now we have to explore other reasons. Half the time, the session is education, because if you know what you're dealing with, then you can help solve the problem. So a lot of my it is education, and it's more than 5 minutes in an office. It is 60 minutes of one-on-one, making sure you understand what you're dealing with. So, but yeah, all the layers of that onion, how the inner ear controls the eyes. How many people have you talked to that I'll put my goggles on a patient and their eyes are turning and they're like, those goggles let you see inside your ear? I'm like, I did not explain myself well. No, the inner ear controls the eyes. So yes,
That's
yeah,
one
you
of my that's one of my favorite misconceptions. My other
yeah.
favorite misconception is, so are these crystals gonna fall out of my ear? Like I've had patients like expect after a reposition
Mhm.
we're gonna have like a little pile of sand on the treatment table. It's like, hold
Yeah,
on, let me explain how this works again because I did not articulate myself very
yeah.
well.
Yeah, I actually did have a patient who gave me a stone as a present
Oh my
and said,
gosh.
"Thanks for getting rid of my stone." She,
Oh,
like,
that's
opened up
good.
a jewelry box, and it was very pretty, but it was kind of a joke, but yeah, she's like, "I don't want this back ever. It's yours."
That's fantastic. So I
Yeah.
think we've kind of touched on, there's these different types of dizziness, and
Mhm.
I'm sure you're like me. I could go on for hours about that, but if I wanted to make like a concise, how do I tell if it's an inner ear, a brain, or other? I'll call it other because that's the easiest way to describe it.
Mhm.
To me, I think, okay, the BPPV is the most common
Mhm.
diagnosis. Is that
Mhm.
I think that still holds true, although vestibular migraine is starting to give it a run for its money.
Yeah, and I've always remembered neuronitis is up in the top 3. I don't know if the vestibular migraines has bumped that out. But yeah, BPPV, vestibular migraines, neuronitis. And migraines are a funny one because that has so many overlapping triggers. So those would be the top 3. Um, and if somebody is trying to figure out how to tell their provider what they're experiencing, tempo. I always look for tempo. So how long a symptom will last. I think that gives me a big idea of what we're dealing with. So what I mean by that is,
Ooh, I would be oh, I'm sorry. Go ahead. I cut you
well,
off.
was it 1 to 2 seconds long that you experienced your symptom? Was it 30 to 60 seconds? Is it 5 minutes? Is it constant and with you all day long? I really try to identify the duration of their onset of symptoms.
I think you touched on another important point, which is, the tempo is probably I could diagnose half of the things I need to
Mhm.
see just based on just
Mhm.
knowing the tempo. Like, but I think the triggers is the other big component. component is
Yeah.
starting to take, do you ever have your patients keep symptom logs?
Yes. Yeah.
Particularly on the more
Absolutely.
complicated ones, it's I was dizzy at this time of day after this type of food, when I was
Hmm.
doing this activity, whether I was inside, outside, was I in a visually complex environment, was I
Yeah.
dehydrated, and was there an orthostatic hypertension component
Mhm.
to it?
And
But
that can be overwhelming. That could be super overwhelming. So I kind of course, same as you probably do, I feed a little bit of maybe BPPV, like see if it happens when this. Nope, didn't happen. All right. So now we're going to see if it happens when this. Um, so it's not so overwhelming. I'll kind of ask them to log that way.
no. And for those listening that may or maybe thinking, okay, do I have this BPPV? Do I have this other thing? What are some of the common triggers you would see for BPPV specifically? Because
Um,
that's our bread and butter. That's the one where those
yeah,
are the easy fixes.
yeah,
If
yeah,
you get into that BPPV category, call one of us
mhm,
as soon as possible.
yeah,
Stop living with this.
yeah.
Help.
So the BPPV classically is going to be a short duration of kind of a room spinning sensation when you lay into bed, get out of bed, bend over, look up, or roll in bed. That does have some caveats. So if you maybe had a virus to the inner ear or some kind of damage, or those who are 65 and older, we have some decreased function of the inner ear, and your presentation is slightly different. It might be more like, I just feel off in my head when I bend over. I don't quite spin, but I feel kind of woozy when I lay into bed. And it doesn't have to be a room spinning, but it can just feel maybe sick to your stomach when you change positions and a little lightheaded. And there's a particular area, horizontal canal, where my patients feel more off, nauseous, and lightheaded with bending over and looking up, and not so much any of the the bed type things. So it doesn't have to be room spinning, but it is short duration based on position.
That's something I know we talked off camera about a little bit is
Mhm.
there's these different canals and each one kind of has its own different subtle presentation. If you read a textbook or before I really became a clinician and was really seeing people like this all day, every day, I would have thought it was just that pure spinning vertigo. Just the
Mhm.
world is spinning. If I look, I can see the world going like this.
Mhm.
Pretty obvious when it happens to you. But the more I learn about it, and this is why vestibular is so challenging, is the more you learn and you learn about your cupulolithiasis versus your canalolithiasis, and okay, these are going to present very different. And we
Mhm.
were talking about an article I read about how, to your point, when the vestibular nerve function starts to decrease as you age, the symptoms aren't going to be as intense as if you were younger. So
Mhm.
learning how to read between the lines, these things can get very blurry and very muddy.
Yeah.
So it's nice. I know you are like me in that I would say half my first session is just listening and understanding and just tell me what you feel and when.
Yeah. Yeah, and so for any like clinicians watching, I just based on the research I've done, anybody who is coming to me with falls or imbalance over 65, I'm automatically going to screen for BPPV just so I don't miss an obvious, uh, diagnosis or problem, and that could solve your issue. And I've seen some second opinions, patients that were just not recovering with your traditional balance therapy, and I'm like, I'm just going to screen you for BPPV because I asked those questions because I'm a vestibular therapist. I didn't just say, the patient, oh, I'm having a balance. Tease it out a little bit more. So I think when you're with a vestibular therapist versus somebody who might not be trained, you're going to look for those responses. She had horizontal canal BPPV, so it was missed for I think 12 sessions. And the doctor said, hey, just give her, go to Amy, have her give her another look because you're not making gains. She had a horizontal canal BPPV. So that's where the nausea came from. That's where the imbalance. And she was back to line dancing and Tai Chi and no problems whatsoever.
The thing about BPPV is, once you have this problem, that these crystals get loose, it's possible for them to go away on their own. It is. There are reports of that, but
Mhm.
until you're getting your head in the right position to get these to clear out,
Mhm.
be living with this problem indefinitely. I'm sure you've seen patients where it's what's your record for the longest time somebody's been dealing with BB?
Oh gosh, I had a retired truck driver, and I swear, like off the top of my head, it was 10 years.
Hmm.
And one session, he thought I was doing voodoo after I said, just see.
Give it a minute.
And it hasn't come back. Got knock on wood, it hasn't come back. And it was one session, and he was like, I don't know what you did, but it's gone. So
Those are our favorite moments as vestibular therapists. It's
yeah.
not always that easy. It's not always
Yeah.
that. But is it just? Oh man, it feels good. It feels so good.
Mhm.
I had a lady that was eight years.
Wow.
She hadn't laid down in bed in 8 years.
Oh,
So
yeah.
she or literally would sleep in a recliner because she was so dizzy. And we didn't even she didn't come to us for dizziness. She came to us for neck and back pain
Neck pain, yeah.
because she was sleeping in a recliner for the last
Mhm.
8 years. And we're like,
Mhm.
we're going through our triage, and it's like, oh, by the way, I feel dizzy every time. Um, like 3, 4 sessions. She had multi-canal. Within
Mhm.
2 weeks, gone.
Wow.
And that
Yeah,
helped.
how do you get past the anxiety of having somebody lie down?
Mm, That's
That's that's the hard part. That's the
that,
hard part too. Like,
that's
it's your choice, but
what's your go-to comforting measures is I always, are you more of the pep talk? Because this a lot of these people, they know when they go into that position, oh, this is going to be
mhm,
like going on a roller coaster. It's like
mm,
it's like going to Cedar Point. It's
yeah.
okay, when
No, I
they're on
definitely
Top Thrill Dragster and it's getting
yeah,
ready to go, and you're like, oh,
yeah. I go low stimulation, I lower my voice, I start talking very slow, pressure, I want you to hold my arm, look right at me, and I just get that super calm, gonna have an ice pack for you, um, just breathe through this and it will stop. So I go the let's zen out. Um,
do you ever go peppermint oil or like lavender?
Peppermint oil, I have peppermint oil that I put on the wrist. And yeah, I have that. I carry that carry that in my toolbox.
You get more. I'm not I tend to be a very evidence based guy. I'm not one to just start throwing essential oils and
Mhm.
everything, but there seems to be pretty good uh, reports of
Yeah.
those types of oils helping with nausea and helping with, it's not going to cure anything, but it can kind of help settle that stomach a little bit if they're that queasy or that anxious and nauseous.
Yeah. I once read a study, the top was peppermint, rubbing alcohol, believe it or not. So like hand sanitizer and just a whiff. That was interesting in that study. And then of course ginger, like a lozenge or something to quell longer lasting nausea. So but
My
yeah.
wife had when she was pregnant. We had back to back Irish twins. My wife was
Mhm.
obsessed with the ginger. Like they make like ginger candies
The
for when she was
gingins.
going like morning sickness. Oh my gosh, it was her. And like that's
Mhm.
kind of what started. I was like, I should have patients try this because this is
Oh
really
yeah.
helping your nausea. It might help other people's nausea.
Yeah, I think on Amazon it's gingins, and you can get those. Those have worked pretty well in the past. So,
Fantastic.
yeah.
So we talked a little bit about the BPPV. Let's kind of talk about some of the more common disorders. We talked about the BPPV. You mentioned the neuritis, or labyrinthitis. They're all kind
Mhm.
of variations of the same general
Yeah,
thing. What
one
do you
with hearing loss, one without. So,
exactly?
mhm.
That's what does that typically look like for your patients?
Onset of neuronitis is it's been interesting, but classically, it's going to be 24 to 72 hours of constant spinning, even though you are in bed and not moving. That room is just going like this, nausea, vomiting. You can still move your arms and legs. There's no confusion, no slurred speech, um, but it could involve hearing loss. It does not have to. Um, and it's that long duration with the nausea and vomiting. Um,
Or the
typically,
BPPV. That's a good distinction for
yeah,
anyone listening who struggles with dizziness. It's the
yeah,
BPPV. It's short bursts when you're moving your head versus the
mhm,
price. It's that like constant.
yeah, yeah, and it's different from migraines, which could be anywhere from 20 minutes to hours long. Again, no hearing loss. You might have a visual aura like a sparkle or a loss of vision. Um, does not have to involve a headache whatsoever for migraine. Your headache can be replaced with just room spinning. So a lot of people have a misunderstanding of what migraine can look like. So so that's the two uh, main ones that we're going to see in episodes or spells. But going back to neuronitis, a lot of people will wind up in the emergency room because it's very scary. Some of my healthier or maybe even younger patients, sometimes the presentation is shorter, believe it or not. It's almost like their body's kicking that virus a little bit. So it's still longer duration, 20 minutes, 24 hours, but it's sometimes just like a 5 out of 10 as opposed to a 10 out of 10. So it's interesting. I love to see those patients pretty quickly because you can put the goggles on them and see what their eyes are doing, and get a better grasp or diagnosis. Those respond pretty well. I would say go to the doctor. If I see them first, go to the doctor. Let's see if an antiviral or a steroid pack is appropriate for you. We'll confer with the doctor. And then vestibular exercises are very effective in getting you a quicker recovery. People will recover without vestibular therapy, but they might have a harder recovery, longer recovery. Um, and who needs that? If you can get into your therapy quicker and you're recovered from this in 4 weeks, why not do that as opposed to 6 weeks, or I should say 6 months, and then letting some other condition develop because you don't understand what's happening. And
Gonna live 100% in 6 months if you do nothing.
what's that?
I said, you're also assuming if you do nothing, it's going to resolve 100%. A lot
Yeah,
of
and
people will have residual deficits for
you'll have residual, but some people, the doctors might say, "Oh, you're good enough." Like, no, like I want to run again. I want to turn without feeling dizzy. So there's feeling good enough and getting back to yourself. And I mean, the evidence is out there, that vestibular therapy by far is the treatment you need for neuronitis. So I just wish that we would get those cases a little bit more than I currently see.
I agree. And tell me a little bit about, what are kind of your go-to treatments if somebody's thinking about, coming to see Amy? Like, they say these vestibular exercises. I have no clue what that means. What would be some general strategies you would have people try at home?
So gaze stability exercises are what you're going to receive and what you'll see. I've seen a lot of YouTube videos out there, from different providers who are not classically trained, and they're saying that this is a gaze stability exercise. That is not an inner ear exercise, and I find that some of the information put out there is just very harmful, to patients. And they say, well, I did vestibular therapy, so what's the point? Um, and that's really upsetting. So when you do look for a vestibular therapist, look on the Vita website. There's a directory of therapists who, are trained with the inner ear, and you're going to get exercises that actually help. So gaze stability exercises are exercises basically that involve small motions of the head. You're locking your eyes on a target. So we have mentioned before that your inner ear controls eye movements. It's a naturally occurring reflex that when you move your head, your eyes shift the opposite way. So it's basically called vestibular, or VOR exercises. And there's a whole progression to that. I have seen a lot of patients who didn't quite fully recover, and they were never taken to their level. So, what I mean by that is, yeah, my therapist had me do these exercises, and I just went like this, and I sat and I did that for 4 weeks. And I said, okay, well, the inner ear functions at a much higher speed, and you're an active, runner. So sitting is not going to challenge your inner ear enough. We need to be doing these exercises outside. We need to be doing these exercises on a treadmill. So I always match. Yeah, I that's where I see things go wrong a lot of time. People don't get 100% because we have not met the capacity of the inner ear for those patients.
Are you a metronome fan?
Yes, I have it on my phone and I share it with patients.
Do you do an app or do you just Google metronome? Because I find I can Google metronome and do the Google one faster than an app.
Oh, I have my free app and it has a timer, so I really like it. Yeah.
What's the fastest you've got to be up to? Do you ever get past like, a 180, 200,
I will go from 180 to 240.
240?
Mm-hmm.
So
So,
for anybody listening at home, what we're talking about is, you'll do these exercises where, I always tell people look at their thumb or look at a target and you're going to a beat. And 240 is about,
yeah,
I have
bum,
no
bum,
rhythm,
bum,
but
bum,
I'm
bum, bum,
guessing
bum, bum,
somewhere in
bum,
there.
bum.
So, you're
Yep.
doing some degree of this. And,
Mm-hmm.
some people will do bigger range of motion. Some people will do smaller. Uh,
Mm-hmm.
One of the big mistakes I see is most people will just do one plane. Well,
Mm-hmm.
your ears are responsible for multiple movements, just
Yeah.
not just this. It's okay. Okay, you got to do this in here. You got to
Mm-hmm.
do this in roll. You got to do this in pitch. You got to try all these different planes.
Mm-hmm.
Make sure your eyes can respond appropriately.
Yeah. Yeah, I think that would be the harder of the moves for sure with neck issues. But yeah, multiple planes, and it's effective. I mean, after I don't know, 10 years of doing this, I'm still amazed every time that these exercises work. I know, just trust me, it does work. The research is out there and it works.
Started really pushing people with the metronome because early on, it was just when I started dabbling. It was just, I remember gaze stabilization. I remember VOR one
Mhm,
times two, and then it was
mhm,
like, okay, how do we do this the right way? And it's okay. Let's build a graded framework.
mhm.
Let's start. If you lift weights, you don't just grab a weight and then just throw it around, and then grab a different weight and throw it around and hope you're progressing the right way.
Yeah.
We have to start. Okay, let's lift 10 pounds before we lift 15 pounds. Now let's lift
Mhm.
15 before we lift 20, and so on and so forth.
Yeah.
That's a big mistake I see a lot of people make is they just kind of just grab what they think is difficult and they don't do it in a nice sequential manner.
Yeah. Or they're like, I move my head when I'm mowing the lawn. Like, that's a good try. But, nope, it doesn't match with your capacity. So you have symptoms when you're walking outside. We will practice walking outside. And that takes a few weeks to get there. Most of the patients that we see, and Erin, I'm sure you could speak to this, um, sometimes I've had to start them laying down. Like maybe if it's a post acoustic neuroma surgery and that nerve was severed, we're laying in the hospital bed and they're doing VOR exercises, laying down. And then weeks, months later, we're actually walking outside doing those exercises. It's not like we start day one with the most challenging. We definitely grade that up because we want a slight amount of symptoms, um, but then quickly abate.
Like
So if
Goldilocks region.
yes, yep, you have to get dizzy to get better.
Challenge yourself to improve. That
Hmm.
kind of is how life works, unfortunately.
There you go. Yeah.
So we've been talking a lot about, the different conditions, and I could talk to you for 20
Mhm.
hours about that, but I want to talk a little bit about your business model and what your practice does and how people can find you. So you are doing the mobile concierge. So that's,
Yeah.
as I understand it, that's telehealth plus home house calls
In
going in.
in-home or office visits. So why I was attracted to this basically, I started during the pandemic. I have I was frustrated because people maybe couldn't get to the clinic. I worked in an outpatient neuro clinic, which I love. And I just really know that I can help people and solve these problems. So when people had transportation issues or they had, kids that they couldn't leave, their husbands or wives couldn't take time off of work to get the patient to the clinic, it was like, that's so sad that these people can't get better because of barriers. Not because they don't want to, just barriers. Um,
Vestibular rehab, that transportation becomes even more of a thing. It's one thing if you have a broken leg and it's your left leg and you can still drive. It's
yeah,
another thing if you get dizzy when you move your head and you have to.
yeah. That's why I was like, why come to me? I'll drive to you because you're dizzy. Like that, who wants to drive when they're dizzy? So that was the genesis of this business, because there, the barriers to recovery, I wanted to overcome that. So I started out with just vestibular. I'm the only mobile vestibular therapist in Northeast Ohio. I have all the stuff that you would find in the clinic and probably more. I also use virtual reality, the Oculus for people who have 3PD. That's basically dizziness triggered by some visual disturbances. So I use virtual reality. I use the infrared goggles that you would find in the clinic. Have my own treatment table, and I come to you. So I set that all up, and basically the concierge portion is that we provide individualized care with a specialist, one-on-one for 60 plus minutes at a flat rate. You have access to me after our session via email, text, or follow-up questions. And I'm always calling in to, check on you, make sure there's nothing else that you need. And if there's an emergency, I try to get patients within 48 hours. So that's also a bit of the concierge is quick access. You don't have to wait 2 weeks or 3 weeks to get into a clinic. So try to pride ourselves on how quick the access is to care as well. So you can get on your life, get back to work, start playing with your kids, and feeling better as soon as possible.
Love your life. I wish I should have had my love your life sign in the background. Missed marketing opportunity for physical. It's gonna give me a hard time for that one.
Uh,
I love it. I love it. No,
mhm.
I really do love the work that you're doing.
Um,
This vestibular therapy is as the baby boomer population starts to get up there. Not that dizziness can't affect the younger generation, but there's a lot of people that are going to be suffering. Um, People just don't realize that this is a thing. People don't realize that it can improve. Nothing irks me more than somebody saying, "Well, I'm just my balance is bad because I'm getting older, or I'm just dizzy because I'm getting older." No, there's a lot of old people that are not dizzy, and there's a lot of older people that do not have trouble with their balance. If you have
Mhm.
a pathology, and that pathology can be fixed pretty easily,
Yeah.
let's take care of it. Let's do the right things. Let's get you feeling better.
Mhm.
So it's something that I'm very passionate. I can tell you are as well.
Mhm.
It's been tough for me. And I normally try and bite my tongue a lot in these things because I don't want to step on other people's toes. And I'm like,
Mhm.
I cannot shut up during this interview because I just want to talk about this stupid because I'm so passionate about it. I'm like trying to tell myself, I'm like, don't talk, don't talk. I'm like, I want to say this, I want to jump in. I'm like, nope, it's
Uh,
all about Amy today.
mhm.
But no, I appreciate you so much for your time, Amy. If people are looking for you, if people are wanting you to come out and come to their house or maybe do a telehealth session, what's a good website for you? How do they get in contact with you?
So the easiest way is to just Google custom care rehab online. It takes you right to our website, and you can submit an inquiry, and we can connect and do a phone call visit after that, just a discovery visit, or email Amy at customcarerehab.com.
I'll make sure we put that links to everything on here. Keep doing the work that you're doing. Is there anything else we didn't get to touch about? Where I have another thing. I know you have another thing, so I know we're pressed for time. But
No,
this,
I think that
this
was great,
uh,
and hopefully, and people in the community have found it beneficial. Thank you, Erin, so much for having me. Your passion and what you do for the community. Thank you.